Okay, hello guys, good evening. I hope I'm audible. I hope the voice is clear, the video is clear. Good evening, everyone. This is Dr. Nilesh, your faculty for Pharmacology from DocTutorials. Okay, hello. Okay, here we are going to be starting with the first of its kind vertical integration session between anatomy and pharmacology of the topic acute coronary syndrome. This is an important topic recently. Why? Because there is a recent update which has been released from the AHA. In 2025 January, they released and they and they were updating it on a frequent basis. And even the last June, we got an update of that document which was released. And based on that, and based on the latest guidelines, which is to be used for the treatment of acute coronary syndrome, this topic has been selected, and we'll be proceeding with that. And with this, I request and I sincerely welcome Dr. Tejaswi sir. Hello, sir. Welcome, sir.
Thank you, sir. Thank you, sir.
Yes, sir. I welcome Dr. Tejaswi sir, our anatomy faculty of DocTutorials, MBBS curriculum. Sir is like an most vibrant personality in anatomy, and he's been working as a professor and HOD of Department of Anatomy from Adi Chinchinagiri Institute of Medical Sciences, Bellore, Karnataka. And I think we'll be starting the discussion in like few minutes. Sir will be covering up how exactly and what exactly is the anatomy of the blood supply and the clinical anatomical concepts as related to that. And once you understand the basics of how the blood supply is actually been, and from that we'll take care of the pathophysiological concepts, the pharmacological concepts, and the latest guidelines used in the treatment. All of this will be taking care of it in a sequential manner. And the stage is yours, Tejaswi sir. I think you can start the discussion for the anatomical concepts, sir. Thank you so much for being here.
Thank you, sir.
You're on mute. Sequence. Yes, sir.
Thanks again for the kind introduction, sir. And it's been a proud moment for me to share the screen with Nilesh, sir. I think one of the legends of pharmacology. Thank you very much for the opportunity, sir. I think this is a novel attempt. Usually we focus on aligning anatomy with physiology or aligning anatomy with surgery. Now here we are trying to integrate anatomy with pharmacology. I once again thank Nilesh sir for this opportunity, and will directly dive into the topic actually. So the whole topic in general is on acute coronary syndromes, and it's always better to start with knowing about the arterial supply of the heart. Let's imagine you are a first year student, or you are like a final year student, or an intern, or a graduate who is actually giving entrance exam. And this is the question that you come up with. Okay, let's read the question first. So we have a 54-year-old male who was brought to emergency with sudden onset of severe chest pain radiating to the jaw. The moment we see this, we know that possibly here we are talking about a case of myocardial infarction, right? But let's be patient and read the whole question. So jaw and medial side of the left arm, right? Associated with profuse sweating. So the clinical symptoms are suggesting towards possible myocardial infarction. And then further evaluation revealed myocardial infarction. So the diagnosis is given, suggesting that anterior wall is infarcted. So further evaluation could be in the form of ECG, right? But this is showing anterior wall myocardial infarction, right? So now the question is, which artery is most likely to be occluded? Which coronary artery is most likely to be occluded? And then discuss the arterial supply of the heart. So if you are looking at an MCQ, the question would possibly stop here. If we are looking at first year MBBS professional exam, this is where the question would continue. Are we clear? So now let's try to approach the arterial supply of the heart, right? So let's see if we can answer the first question. So what is the possible artery that is occluded here? So the clue here is, this is a case of anterior wall MI. Now, we would have studied the arterial supply of the heart in detail. We would have learnt about the coronary arteries, their course, branches, area of distribution. But usually what mistake as students we tend to do is, we tend to neglect the branches and what area they supply. Right? Now, this is one particular region apart from the brain where we need to know the exact name of the branch and what area does it supply, so that if that artery or that branch is occluded, a particular part of the anatomical structure will undergo ischemia and necrosis. Right? So, in anterior wall MI, which is the possible artery that is involved? Now, the answer for this question, let's say, is we will write it as left anterior descending artery, right? Or commonly called as left anterior interventricular artery. Now, this supplies majority of the anterior wall of the myocardium, right? Now, once we have come across what artery is being affected, right, or possibly occluded, if we are a first year medical student, how we go on discussing the arterial supply of the heart. Even if we are in second year, third year, or fourth year trying to learn the pathophysiology or the medical concepts or medicine concepts of myocardial infarction, it's always better to begin with a brief introduction to the coronary arterial supply. And it is always better to keep learning about the arterial supply of the heart under what are the arteries. Of course, we have two coronary arteries, all of us know. But in that, what we must know is how exactly these coronary arteries take their origin, from which parental artery they come from. First point. What is the fate of each of these arteries? How right coronary artery would end? How left coronary artery would end? This should be the second point, right? Then, once we have learnt it, since we are confined to the viscera, let's not worry about the extent of the artery. We can discuss about a brief course and relations. Then, the most important aspect of any artery in the body, I would say, is knowing the branches and area of distribution. And unfortunately, this is possibly the most neglected component of any artery. So let's focus on that today. And of course, we can end it with a little bit of clinical anatomy about the arterial supply. Right? Now, what we have here is we have the images showing the different anatomical aspect of the arterial supply of the heart. We will take up each diagram and we'll continue to discuss it as we progress. First, how do we discuss about the arterial supply of the heart? Right? Now, first point, as I said, is origin. So from where does right coronary artery and left coronary artery come from? The right coronary artery actually comes from the anterior aortic sinus. This is a frequently asked MCQ question in entrance exam. What is the origin of the right coronary artery and the left coronary artery? The left coronary artery arises from the left anterior aortic, or what we call this as this is not anterior, this is the left posterior aortic sinus. So anterior aortic sinus and left posterior. Once we have learnt it, let's take a look at what exactly these coronary sinus mean. So what we have here is the ascending aorta, which has been cut to show the sinuses. This is the aortic sinus. So here we have the anterior aortic sinus, which gives rise to the right coronary artery, the left posterior aortic sinus, which gives origin to the left coronary artery, the right posterior sinus. Okay. Now this is very peculiar. This is called as the non-coronary sinus because it does not give origin to any coronary artery. Are we clear? Right. This is regarding the origin, and this gives us a better understanding of what are aortic sinuses. This is a very important MCQ for your entrance exam, right? Then, once we have learned this, let's focus on how do they terminate. The right coronary artery terminates by anastomosing with the left circumflex artery. This occurs in about 60% of the individuals. In other 40%, either it ends at the inferior border of the heart or traverses the posterior part of atrioventricular groove completely. We will see the diagram and then we'll try to understand. Then, what about left coronary artery? The left coronary artery actually terminates by dividing into two terminal branches immediately. So the left coronary artery has a very short course that lies between the pulmonary trunk and the left auricle, and immediately terminates by dividing into two branches. These are anterior interventricular artery, which is occluded in this case, and the left circumflex artery. So this is what we mean by termination. How exactly the artery terminates, this is how we explain. Hope this is clear. Then, little bit about the course and relations. Okay. Now, there is similarity in the course and relations of both the arteries, which is again frequently asked as an MCQ question. At the origin, both right coronary artery and left coronary artery pass between the right auricle and the pulmonary trunk, whereas the left coronary artery passes between the pulmonary trunk and the left auricle. So this is a very important point we need to remember. Coronary artery lies in between the pulmonary artery in front and the auricle behind in both right and left coronary arteries, right? Then what about the rest of the course? Left coronary artery immediately terminates into two branches. What happens to right coronary artery? Right coronary artery runs in the right part of atrioventricular groove and ends at crux of the heart. Now let's try to understand this with the help of these two diagrams. So what we have here is the other two diagrams which are showing the course of the right and the left coronary artery. So here we have the right coronary artery passing between the pulmonary trunk and the right auricle, then traversing the right part of atrioventricular groove. And if we see the posterior surface, we can see the trunk of the right coronary artery trying to anastomose with the left circumflex artery at the crux of the heart. Crux of the heart is the point where the atrioventricular groove, the interatrial groove, and the posterior interventricular groove, all of them meet, right? So this is the course of right coronary artery. Left coronary artery, as we can see, is very short, divides into the left anterior descending artery and the left circumflex artery. This is all we need to know in the course and relations. Once we have learned this, comes the most important part of the entire arterial supply of the heart, right? To me, this is the crux of the arterial supply of the heart. We need to know the name of the branch and the area it supplies in order to know which artery is blocked in a particular wall infarction, right? So let's begin with the right coronary artery. The right coronary artery gives off following branches. The first branch is called as conus artery. Remember, whenever we use the term conus, we are referring to the pulmonary infundibulum, right? So right conus artery supplies the infundibulum of the right ventricle. So again, I'll repeat, conus refers to the infundibulum of the ventricle, right ventricle. Then anterior ventricular rami. As the name suggests, what it should supply? It should supply the anterior surface of the ventricle. Which ventricle? Predominantly right ventricle and partly the left ventricle. So what we need to remember here is this supplies the sternocostal surface, which is also referred to as the anterior surface of the heart, right? Then atrial rami, right? These atrial rami supply the right atrium, but again anterior surface. So conus artery, ventricular artery, atrial rami. Now we have an artery called as SAN artery. Remember, in 60% of the cases, SA nodal artery arises from the right coronary artery. As the name suggests, this supplies the sinoatrial node. Are we clear? This again is a very important MCQ question. Next, we have the posterior ventricular rami. As the name suggests, posterior ventricular rami. They supply the right ventricle. But what surface? As the name suggests, this supplies the posterior surface of the right ventricle. Are we clear? Right. Then we have the posterior interventricular artery. Again, this is one more important artery that we must never forget. Okay, posterior coronary or posterior interventricular artery actually defines the coronary predominance, as we will discuss a little bit later, right? So what does posterior interventricular artery supply? This you must never forget. So we will use a different color here. Posterior interventricular artery supplies the posterior and the diaphragmatic surface, which is also called as the inferior surface of the heart, which rests on the diaphragm. So inferior surface of the right ventricle and also part of the left ventricle is supplied by this posterior interventricular artery. Apart from this, this also supplies the posterior inferior 1/3 of the interventricular septum. So remember, the major artery that supplies the interventricular septum is the anterior interventricular artery, which is a branch of left coronary artery. But the posterior inferior 1/3 is actually supplied by the posterior inferior 1/3 of interventricular septum is supplied by posterior interventricular artery. So as I said, these two we must never forget. Okay. Then the other branches, the right posterior atrial rami, as the name suggests, this supplies the posterior surface of the right atrium. So if we summarize, the right coronary artery mainly supplies the entire right atrium, the infundibulum of the right ventricle, the sinoatrial node, anterior surface of the right ventricle and partly the left ventricle, but the entire posterior surface of the right ventricle, the diaphragmatic surface of the right ventricle, as well as the diaphragmatic surface of a strip of left ventricle, including the posterior inferior 1/3 of the interventricular septum. Done. As I said, this is a must. We must know name of the branch and the area that it supplies. And if you know this table, nothing like it. Done. Now let's move on to the left coronary artery. Left coronary artery gives off two major branches. One is the anterior interventricular artery, which is also called as the left anterior descending artery. Now this again is a major artery. This is the most common artery involved in myocardial infarction also. Right. So what is the area supplied by the anterior interventricular artery? Remember, anterior interventricular artery supplies the sternocostal surface of the left ventricle. Sternocostal surface of the left ventricle, right? That is one. Then this supplies the anterosuperior 2/3 of the interventricular septum. So this is the major artery that supplies the interventricular septum and majority of the left ventricle. Now, since it supplies majority of the left ventricle, occlusion of this artery, if complete blockage of left anterior descending artery occurs, it usually results in a fatal myocardial infarction, and hence this artery is also called as the widowmaker's artery. So left anterior descending artery or anterior interventricular artery is also called as the widowmaker's artery. Are we clear? Apart from this, the left coronary artery also gives off circumflex branch, which can give rise to the left marginal artery, the posterior interventricular artery, SAN artery, and atrial branch. All of these branches put together will supply the left atrium as well as the left ventricle. So entire left ventricle, including the sternocostal surface and the diaphragmatic surface, the left auricle or the left atrium, this is supplied by the left coronary artery. So this is what we need to know. Name of the branch and the area it supplies. Ultimately, why we should know. Imagine there is a patient who presents with anterior wall MI as we just saw. The majority of the anterior wall, as we just discussed, is supplied by the left anterior descending artery, and hence the artery occluded in this case is the left anterior descending artery. So when they give the diagnosis, you should be able to pick. If the ECG changes show anterior wall MI or inferior wall MI, you should be able to pick the artery that is involved. So once we have learned this, Nilesh sir will take you through the entire clinical anatomy or the medicine part of myocardial infarction. But before that, few words on the clinical anatomy of the coronary arteries. First, what do we mean by coronary predominance? In coronary predominance, we have two types. One is right coronary predominance and left coronary predominance. In 60% of us, we have right coronary predominance, which means the posterior interventricular artery is a branch of right coronary artery. If it comes from left coronary artery, we call it as left coronary predominance or left coronary dominance. First concept. Widowmaker's artery we just discussed. 100% occlusion of left anterior descending artery is fatal. That is why we call it as widowmaker's artery. Right? Then circumflex artery, what is the clinical importance we need to know? Circumflex artery lies very close to the mitral valve. So this is the most common artery that gets injured during mitral valve replacement. So this is one more important clinical anatomy we need to remember. Done? Then myocardial infarction, which is caused by sudden occlusion of arterial supply to myocardium, can result in necrosis of the myocardium. Now, this is caused by occlusion of coronary arteries, but the most common artery involved again is the left anterior descending artery, which is a branch of left coronary artery. Then we have the trunk of the right coronary artery, which is commonly involved. And the third artery to be involved is the circumflex artery. So in the frequency of involvement, this is how the arteries of the heart can get blocked. Right? So this is regarding a brief overview of how the heart is supplied by two major coronary arteries. Again, I'll repeat, what we need to know ultimately is this table where we have listed the branches of each coronary artery and the area supplied by each of these arteries. Right? This is what will be asked in exams, and this is what we must know as doctors, because once we start practicing, we will see a lot of cases of ischemic heart disease, and we should be thorough with this. I hope this session will help to set the foundation for the next session on the myocardial infarction. I once again thank Nilesh sir for this opportunity. So thank you very much for this opportunity.
And I hope that the students would have gotten into a lot of important techniques about which is the most common artery. And we have discussed lots of points. Sir has discussed extremely important points about how to proceed on which artery we should target on. And now comes the famous question, right? Just give me a minute. Okay. So now comes the famous question, like, sir, how could proceed further? Okay, we could understand how the artery works and how the supply works. We'll look into what are the current pathophysiological process. If any clot is being formed, how the clot is getting actually being formed, and how it is progressing onto a complete blockade, as sir was explaining the LAD artery, which is the most common one, the widowmaker artery. How this blockade is going to be increasing up, no? Like how can we differentiate it from a normal angina, and how a patient can progress on to the further diseases like acute coronary syndrome, and how to manage it based on the recent guidelines. We'll be discussing that in a jiffy. And for those students who are watching this video live in the YouTube, the workbook for this particular session has been pinned up. The Google Drive folder has been pinned up in the chat box. If you are planning to discuss, if you're planning to take down notes, you can take down from that. You can download the document from that, and you can take the notes in it also. Okay, so we'll start with the further processes. First of all, as Sir was clearly explaining, this is about an arterial blockade. So how the blockade is actually been happening, it is not going to be on a sudden onset. It is going to be on a gradual way. For example, consider here is where your blood vessel is, okay? And consider here is where your blood vessel is. We have an atherosclerotic plaque which is blocking up the area in a partial way, right? So we can see that atherosclerotic plaque in that video. So if in case there is any blockade in the atherosclerotic plaque, okay, if there is any blockade in the atherosclerotic plaque, it is just going to be decreasing the blood supply to the target organs, which is your cardiac muscle over here. But here, there is something else which is happening due to some stress factors. Stress factors, which includes stress factors like smoking, heavy smoking, or the patient is already under hypertension, or there is too much amount of lipid accumulations. In those cases, there might be two different areas in which this clot might progress on to acute coronary syndrome, or simply here in this process, we'll be discussing in detail about STEMI. So what is STEMI? ST segment elevated myocardial infarction. We'll be spending a lot of time in understanding about what the treatment process and how the pathophysiological process of STEMI actually looks like. So smoking, hypertension, or in terms of liquid accumulation, there might be that blockade which is happening. It might be of two different types. Either there might be a slow developing stenosis, or the stenosis might be rapid. Mostly in terms of a slow development of the stenosis due to constant accumulation of the lipid leading on to increased due to constant accumulation of the lipid due to increased that atherosclerotic plaque which is happening, it is going to be gradual in nature. In those areas, usually collaterals will be formed. I hope you know what is a collateral is. In terms of a blockade of a particular area, nearby blood vessels will try to create a bypass. You know what is a bypass there, right? If you have a road which is traversing into a small village, what the highways guys do, they will put a bypass surrounding that. So the traffic can be diverted and they can join back after that like a traffic area has been crossed off. Similarly, there will be a bypass which is happening there by the physiological or the pathological processes itself. There is no need for a drug influx here. These are named as collaterals. These collaterals which are formed will prevent the progression of that patient to STEMI. Usually these patients will not progress on to STEMI, but in case if there is any rapidly developing stenosis, as we can see on the other hand, I'll be explaining about how this stenosis might be rapidly developing. In those cases, there is no time for the collaterals to be formed, and those patients are the one which might rapidly progress on to STEMI. So here what we are trying to explain is not all patients will progress on to STEMI. Those patients which are having rapid progression to stenosis or slow progression to stenosis. Fantastic. Rapid progression to stenosis, those patients are more prone to land up or progress on to STEMI, ST segment elevated myocardial infarction. Okay, now we'll look into how this rapid progression to stenosis actually happens. We'll be talking about that. So the most common cause of STEMI is C. Consider here is where your blood vessel is. Okay. Here is where your blood vessel, any coronary artery, like as sir has explained, any coronary artery it might be. And here is where your atherosclerotic plaque is. Okay. We have the atherosclerotic plaque here. So initially what happens, not all the plaques is going to be progressing on to STEMI. Only those plaques which has got a thin fibrous cap and rich lipid core, as we can see here, those plaques which has got a thin fibrous cap and a rich lipid core, those are more prone to land up in disruption of that particular cap. Okay, what is exactly is disruption of the cap? As we can see, disruption of atherosclerotic plaque, which contains thin fibrous cap and a rich lipid core. This area is going to get disrupted. Okay, when that area is getting disrupted, the contents are getting exposed off to the blood, and that is where superadded blood clot will start to occur. So if we have a blood clots, we used to call them as a thrombus. If it is attached to a blood vessel, if it is fixed onto a particular area, we will be calling it as a mural thrombus. So those areas which are getting exposed off to the blood, the platelets will get accumulated. So too much amount of platelet accumulation, thromboxane A2, which will further increase the platelet accumulation. Vasoconstriction, all these things together will create a bigger mural thrombus on the top of this atherosclerotic plaque, and that is what been explained here. mural thrombus will be formed over the surface. So this is how the rapid development of stenosis actually occurs. So as we told, not all the atherosclerotic plaque will progress on to a mural thrombus. Only those which has got a rich like a lipid core and a thin fibrous cap, this will land up in disruption, leading on to platelet accumulation, thromboxane A2 release, which in turn will produce a mural thrombus. So when the mural thrombus happens, as we can see over here, can the blood which is coming here flow up? No, there is no place for the blood to flow back into that area. Thereby, the opposite muscles which is there on the other side, those which is receiving the blood supply, will be lack of it. And that's how a patient will progress on to STEMI. I hope I'm clear till now. So what we have discussed till now, 2 points: which patients are more prone to progress on to STEMI and how those patients are progressing on to STEMI. We have discussed about the pathophysiological features. Now let's look into how actually those patients will present with. Sir, I have one famous doubt. Sir, I have heard about embolism, right? What about there is a DVT, deep vein thrombosis is there? And those thrombosis, what if it is getting dislodged from that and it is going up and blocking the coronary artery? We have discussed about pulmonary embolism. I think the last session was pulmonary embolism. But why can't there might be an embolism which is happening in the coronary artery? As like Tejaswi sir was explaining, please look into the diameter of these arteries. Right? There might be a very higher level of blockade when that embolism is traveling from a different side. So simply put, embolus induced blockade is very much rare. It is not a common form, guys. Embolus induced blockade is very much rare for STEMI. It is common. That is the only accepted mechanism for pulmonary embolism, but that is not the accepted mechanism for a myocardial infarction. Now we'll discuss about the clinical features guide, how the patient is actually been presenting with. Please note down that most of the cases, more than 50% of the cases who are presenting with myocardial infarction will be exposed to a particular risk factor. They will be having a history of the exposure to a risk factor. Risk factor for STEMI, right? Acute progression to STEMI, not like angina. There might be lots of risk factors for angina, but acute progression, no sudden onset of chest pain or a very severe STEMI, there might be some risk factors like vigorous exercises. There might be vigorous exercise, or patients might land up in emotional stress. These are the risk factors which patients might progress on to development of STEMI. First point done. What's the most common time, guys? Most of you would have easily guessed, no, right? Like early morning times. See, when we were doing our internship, when we were just there in the casualty, we know that most of us will be sleeping up in the casualty, because it's not like we are completely awake during the night times. Every doctor used to sleep in the casualty, just on the chair. We just go back and put our legs on the table and just start sleeping. And I'll ask the staff nurse, like, nurse, if some case comes, please wake me up. That's the usual thing which we do. So whenever you're just lying down and you can clearly hear that ambulance sound, or you can hear the stretcher sound which is there, which is patient is coming up towards you. You just wake up with the sound. You look into the time. If it is early morning, most of you can easily diagnose that this patient is going to be a MI. Right? And most of the time it actually works out, because if it is late night, like 11 o'clock or 12 o'clock, it's going to be DD, right? Drunk driving, and patient would have landed up in RTA followed by DD. Most common case, these are the time in which circadian rhythm in the casualty. That's the common thing which happens. But here, as most of you would have guessed, the most common time of presentation is within few hours after awakening. Within few hours after awakening, mostly like within like early morning times. That's the usual time for circadian rhythm to development of myocardial infarction. What's the most common symptom? Most of you can easily guess it. No, what's going to be there for the patient? Fantastic. Chest pain will be there. There will be severe pain which is happening. Now we have lots of questions for that particular pain itself. These are all the questions which is important for your practical exams, guys. When you say the history in your case presentation, there is no history of chest pain for the patient, and the externals will clearly ask, what do you want to know about the chest pain? Right? So all the characteristic features of the pain is very much important for the practicals. We're going to be explaining that. Now, how this pain is actually going to look like? Is it going to be deep or superficial? That is going to be a deep visceral pain. Okay. A beautiful terminology. There will be a deep visceral pain. The patient cannot actually localize where the pain is, but somehow it is going to be happening inside. But most of the time, the patient will be representing, instead of pain, patient might not be having pain. Most of the time, it will be represented as the chest is feeling heavy. The first common feature presenting complaint is chest is feeling heavy, or there might be a squeezing type of discomfort, or it is going to be a crushing type of a discomfort which is developed over that chest region. The classical feature, pain feature, is very much rare, but mostly that a heavy feel or a discomfort or a squeezing type of feel or a crushing type of feel is the usual thing which the patient actually develops. Now, when it is going to get developed, guys, when the patient is resting or when the patient is under strenuous work. As I've told, more than 50% of the cases, they might progress on with some risk factors like rigorous exercise or emotional stress or something else. But it might be occurring even at rest, or it might occur as strenuous work. During work, no morning, the patient goes and the patient exercises, but pulls some lot of weight and it suddenly feels chest pain. Usually, that's what we explain as angina. When the patient rests and just takes a deep breath and the patient relax, slowly the pain will fade away. That's what we call as a stable angina. But here, this pain which is developed even after strenuous physical activity, it will not be relieved after rest. It will not be relieved at rest. So even if the patient goes back, sits down, relaxes, that pain will not be relieved back. Well, that is when we have to suspect the patient might progress on to myocardial infarction. Which part of chest? Is it going to be like upper area or in the middle part of the chest or the lower part of the chest? The most common area is going to be the central portion of the chest region. The most common area is central portion of the chest region, and sometimes it might progress on to epigastrium too. There might be a pain which is there on the central part of the chest, and there might be a pain over the epigastrium. These are the two most common area where the patient will be feeling this abnormality. Now, you would have most would have known it like chest pain, which is related to myocardial infarction, can progress on, can radiate to certain areas. Of course, most of you would have known the chest pain might radiate on to the left arm, right? Most of the patients might present up with the left arm pain also. It might progress on, it might radiate to arms. It might radiate to the arm. Not only that, guys, this chest pain, please note that not all the myocardial infarction chest pain will be progressive, will be radiating to the arms. Most of that might be localized also. Or it might also progress on, it might also radiate up towards the jaw. It might radiate up to the occipital region also. It might radiate downwards, even towards the abdomen, towards the epigastrium, towards the middle part of the abdomen, middle chamber, but not mostly below the umbilicus. Still, the umbilicus region, the patient will be might be having the radiation of pain, and the pain might radiate on up to the occipital region. It might radiate on to the arms also. It is not a compulsory thing for diagnosis of myocardial infarction. It might radiate to any different parts present in the upper half. And it is mostly associated with, most of you can guess, no, it will be associated with sweating. An intense sweating patient might develop. There might be weakness, the patient cannot even breathe freely. There will be anxiety, very much severe anxiety. The patient will be feeling like there will be a sense of impending doom. The patient will feel that there is something bad which is going to be happening. I'm going to die. That's how the patient will be feeling, that impending sense of doom will be there for the patient. Some patients might also land up in nausea, vomiting also. When the pain occurs, the patient might progress on to nausea, vomiting too. But all these things are primarily the most common causes of, most common symptom which is presented, which is pain. But we have some type of STEMI, which is ST segment elevated myocardial infarction, where the pain might not be there, which we used to call them as a painless STEMI. Now, this painless STEMI can be seen if a patient is a known diabetic or if a patient is elderly. And that's why mostly we can see that very much elderly individuals, more than 80, 90. You would have heard that story that they went for the sleep in the night, the next day morning they didn't wake up. They had a very good death on the bed itself, right? Because those patients will not be having pain. Well, that's the concept of painless STEMI. So diabetes mellitus, or in terms of elderly, they might be having a painless STEMI. But here, how do we actually know? Okay, pain will not be there. Then what will be the presenting symptom in those cases? Dyspnea, or simply breathlessness, will be the presenting symptom. Of course, the sign is going to be dyspnea. I'm not going to the details of it. So breathlessness will be sudden onset. Breathlessness will be the presenting complaint in those cases. So if a patient is a known case of angina, or previously that episode have occurred, and the patient is a known diabetic individual, we have to give them a heads up that if in case you land up in severe or sudden onset of dyspnea or breathlessness, please please have a doubt that you might land up in myocardial infarction. Okay, these are the classical features of the most common symptom, which is chest pain. Now you could know it clearly, right? How actually the pain actually occurs in terms of a myocardial infarction. That's it about your, we have finished. Okay, what all the things which we have understood? We discussed about which patients might progress on to myocardial infarction, pathophysiological process, how it is progressing on, and the clinical presentation, what's the presenting complaint, what about pain, and like how the pain actually happens, and what about the painless STEMI, what about breathlessness, all these symptoms we have discussed. Now let's look into the physical findings, guys. Of course, there will be anxiety. We have discussed that already. Restlessness, persons might land up in perspiration, cool peripheries. Because of intense sweating, the peripheries is going to be extremely cool. But what is something called a strong suggestive of STEMI? Some symptoms will be there which is strongly suggestive of an ST segment elevated myocardial infarction, which is substernal chest pain. There will be a substernal chest pain which is been there for more than or equal to 30 minutes. For more than half an hour, the patient is having up that chest pain along with diaphoresis. What is diaphoresis? Yeah, sweating, abnormal, excessive sweating. So in terms of a substernal chest pain, which is constantly there, even if the patient relaxes, that pain is not gone, and the patient is intensely sweating, that is going to be, like as we told, strong suggestive of myocardial infarction, especially STEMI. Usually, what happens to the heart rate and the blood pressure? Usually, heart rate or the blood pressure will be altered a little bit, but if in case the patient is suffering from an anterior infarction, if in case the patient is suffering from an anterior infarction, or the patient is suffering from an inferior infarction, as sir was previously explaining, anterior and inferior, the most common areas where the patient might land up in a myocardial infarction. Anterior, in fact, they will be stimulating the sympathetic autonomic nervous system, whereas inferior, in fact, will be stimulating the parasympathetic autonomic nervous system. That's what we call as basal-gyrus reflex. So because of this, what exactly can be expected in the patient, guys? We know sympathetic, if it is getting activated, what do you expect the heart rate and the blood pressure going to be? Is it going to be increased or decreased, guys? Yes, please put it up in the chat box when you look into that video. It's going to be increased. But on the other hand, when the parasympathetic system is getting stimulated, the opposite response, there will be bradycardia and hypotension. This is a very important statement, guys, right? If a patient is presenting up with acute chest pain and you look into the heart rate, the patient is suffering from a heart rate of around 50 or 60 beats per minute or even 45 beats per minute. And the BP is very much low, 80-60 millimeter of mercury. You can easily suspect there is development of an inferior wall myocardial infarction. And if the opposite is going to be there, it might be due to any reasons, right? Due to sympathetic activation, but most commonly it's going to be an anterior infarct. Okay, so these are the two major concepts of physical findings, guys: substernal chest pain, diaphoresis, and based on the heart rate, blood pressure, we could narrow down what exactly is the location or the artery which is getting blocked. Now we'll look into the lab findings, guys. What are the different investigations which we have to do if we have if you're suggesting there is myocardial infarction? So you're there in the casualty, patient is brought up to you, severe chest pain, patient is breathless, and there is severe sweating. You look into the blood pressure and the heart rate might be increased or decreased based on the location of the blockade. Now, what's the next investigation which you have to take? We have to know before that, of course, most of you can easily say that ECG is going to be a diagnostic. But before that, let's talk about some pathological features of the lab findings. There might be three different stages in how the disease actually progresses: acute stage, healing stage, and healed stage. Acute stage means within a few hours of the chest pain. Within few hours, this is an important question, guys. Till what time this patient will be there in the acute state? Within a few hours, the acute stage will start. Till 7 days or till 1 week, the patient will be there in the acute stage. Healing stage, it will be there from 7 to 28 days, or simply like 1 month of time, 1 February month. So 7 till 28 days, they will be there in the healing stage. Healed stage means more than or equal to 29 days. And that's what explained as a healed stage. Now, of course, let's look into the ECG, guys. Like we have to take up a 12-lead ECG. We have to take up a 12-lead ECG. It must be taken within 10 minutes of arrival. And after that, mostly we can diagnose, but practically speaking, it is very much difficult to diagnose on the first ECG. Right? So if it is not diagnostic, but the clinical suspicion is extremely high, you are having a very much high doubt that patient might be having a myocardial infarction, but it is not reflecting on the ECG. Just because it is not reflecting on the first ECG, you should not neglect that case, stating that it is nothing but your gastritis. Right? So you have to repeat the ECG every 15 to 30 minutes. The patient should be observed for it. And we have to come up with the criteria. And what exactly is the criteria or to diagnose a ST segment elevated myocardial infarction? Two major concepts, guys. We have to look into the leads of it. In all the leads except for V2 to V3. In all the leads except for V2 to V3, if there is an elevation in the ST segment of more than or equal to 1 millimeter, we can diagnose the patient as STEMI. The first category of how to diagnose the patient with STEMI. This number is important. What about V2 to V3? If it is V2 to V3, then we have to see the gender of the patient. If the patient is a male patient or a female patient. If the patient is male, then based on the age, if he is more than or equal to 40 years of age or less than 40 years of age. If he is elderly, more than or equal to 40 or less than 40. If he is more than or equal to 40, an ST segment elevation of more than or equal to 2 millimeter is diagnostic of STEMI. If the patient is younger and is stronger, less than 40 years of age, even if it is, we can increase it further, 2.5 millimeter, we can diagnose the patient as STEMI. And if the patient is a female patient, irrespective of the age, be it younger or an elderly, more than or equal to just 1.5 millimeter of rise in the ST segment levels, we can diagnose the patient as STEMI, guys. These are the basic criteria of how do we diagnose the patient as ST segment elevated myocardial infarction. This is a very important criteria, guys. This question has been asked multiple times in different exams. Even in your main exams, if you land up in a question for MI, if you could write up this particular criteria, well, that is going to be fetching up maximum marks for you. Okay. With this, as we can see in this diagram, guys, we have a 12-lead ECG. Here is where, I don't know if you can see that in your phone. Please go on to your HD, no? Please click on the HD and look into that image. And here we can see there is an elevated myocardial infarction. There is an elevated ST segment, as we can see. We have multiple different types of ST segment elevation, concave and many different types. I'm not going to the details of it, guys. But again, we'll just stick on to the management processes itself. Now, and one more area, based on the location of the ST segment elevation, we can actually try to find out, as sir was explaining, we can try to find out in which area the blockade can actually be. Three things you have to remember. So I have given a big tabular column here. No, you can either know all the tabular columns, always better for you. But if you want to need, at least give me 3 or 2, sir. I can easily remember it. I'll give you 3 things which you have to remember. The most common one. One is anteroseptal, anterolateral, inferior. Okay, anteroseptal, anterolateral, inferior. At least these 3 you should have to remember it, guys. Anteroseptal is from V1 to V4. In all the areas there will be ST segment elevations, guys. And again, V1 to V2 means septal, V3, V4 means anterior wall, as simple as that. Okay. What about anterolateral? V3, V6, 1 AVL. That is what anterolateral is. V3 to V6, 1 AVL. It's just like you have to repeat. Once you repeat it again and again, that's going to be strict up into your mind, guys. Inferior wall, we have 2, 3, and AVF, like lead 2, lead 3, and AVF, if there is an ST segment elevation there. We have one more concept called as ST depression might also be expected, right? Again, that is a deep into the concepts of how the STEMI can be diagnosed. I don't want to explain that in a detailed way. Okay, so we have 3 different concepts here: V1 to V4, then V3 to V6, 1 AVL, and thereby lead 2, lead 3, and AVF. All of these things are the 3 major concepts: anteroseptal, your anterolateral, and inferior wall MI. At least if you could remember that, it will be very much easier for you. Now, what about the cardiac biomarkers? This is how the ECG we're going to be diagnosing. Now, moving on to the next one, cardiac biomarkers. What exactly are those biomarkers? See, whenever the blood supply is getting blocked, a particular area of muscle is not receiving enough amount of oxygen or blood supply. So what happens? That muscle tend to die. An usual response. When the muscle tend to die, there will be release of certain proteins into the blood. Usually, some proteins will be released out, but most of these things will be taken out by the lymphatic system. But more than that, no excess of what has been drained out in the lymphatics, some will get mixed up with the blood, and those are the only ones which we can diagnose, which we can isolate from the blood investigations. So we have 3 different parts of it. The first one is cardiac specific troponin T, trop T, which we commonly call this. We have trop I, which is cardiac specific troponin I, and we have creatine phosphokinase. One take-home point over here is this trop T and trop I will be raised till 7 to 10 days after the myocardial infarction has been diagnosed. It will be raised for a very long time. So suddenly, if you land up in trop T and trop I, it doesn't mean that patient is suffering from myocardial infarction. Patient might have been diagnosed with MI like 1 week back. It will be positive since very long. Creatine phosphokinase, usually we don't take that into consideration, guys, because we'll explain that why that CK levels is usually not been taken out. Why? Because we need to have a ratio of it, guys, right? We need to have a ratio of CK MB mass and CK activity. Creatine phosphokinase MB mass and the creatine kinase phosphokinase activity. If that ratio is more than or equal to 2.5, then it is going to be suggestive that this particular protein, that CK protein, is released from a myocardial muscle than a skeletal source of the CK-MB elevation. Because any patient, for example, if a patient is under long-term therapy with statins, that patient also might land up in increased CK levels. So you can't actually diagnose it. That is not primarily a diagnostic criteria of how to make a patient or how to think of myocardial infarction. But this ratio can easily be okay, this is this particular protein, because the ratio is extremely high, we can clearly say that it is from the cardiac muscles. So primarily we rely on trop T and trop I. But we have one advantage of this CK-MB. What exactly is that advantage? We'll discuss that in the next one. So what is the order of rise of proteins in the blood vessel following myocardial infarction? This order is very much important. It has been asked multiple times in the previous exams, be it NEET PG or INI-CET. So the first one, initially there will be a rise of myoglobins, guys. Initially there will be an increase in the myoglobin levels after 2 to 3 hours of myocardial infarction. If there is any issues in the blood vessels, within 2 to 3 hours, there will be an increase in the myoglobin levels. CK-MB levels will start to rise within 3 to 6 hours. Troponin levels will start to rise within 3 to 12 hours, whereas LDH levels will start to rise within 24 hours. Okay. Here we have 2 important points to note, which is the first one, myoglobin, which is the last one, LDH. Now the CK-MB levels, which we have told, will reach the peak inside the blood vessel at around 12 to 24 hours, guys. Within like 1 day of time, maximum 1 day of time, the peak level of CK-MB will be attained. But one negative point which we have to explain it will come back to the baseline. It will come back to the baseline within like 2 to 3 days after the onset of myocardial infarction. So if a patient is diagnosed with MI, presenting with chest pain, diagnosed ECG abnormality, and we have trop T, trop I are raised, we have diagnosed the patient. So usually CK-MB levels will be decreased by the end of 3rd day. Now comes the next important question. What if you repeat CK-MB on the 4th or 5th day of the patient is getting admitted and you see a rise in the CK-MB levels? Usually what should happen? It should decrease, guys. It should be decreased, come back to the baseline. But what if there is a rise in the CKMB levels and that ratio is more than or equal to 2.5? Then we can diagnose reinfarct in those cases. I hope you're there with me. So this is primarily being used for the diagnosis of reinfarct to be developed. Right, CKMB is a better marker for a reinfarct because patient is there with you. You can just on a sequential basis, if you take the CKMB levels, if there is a graph is going to be moving up, or if the graph is moving down. If the graph is moving up, you can simply have a suggestive of the patient is landing up in a reinfarct. The second point which you have to know it, what will happen to the LDH levels? Usually, understand it, guys. The LDH, we have multiple different subtypes, isoforms of LDH, lactic dehydrogenase, LDH 1, 2, 3, 4, multiple subtypes are there. Usually in a normal human being, in your body, I hope that I'm also a normal human being, just hair is not there, rest I'm a normal human being. So the LDH2 levels will be more than LDH1 levels. But here in case of MI, the LDH1 levels will be more than LDH2 levels. And why is it happening? Because LDH1 is getting released out from the cardiac muscle. If in case any damage happens there, what happens? The LDL tend to be accumulated more. Usually LDH2 is more, LDH1 is lesser. When the patient is suffering from myocardial infarction, too much release of LDL1, which tends to be more than what your LDL2 levels is going to be. This is explained as flipped LDH levels. This is explained as flipped LDH, which is seen in a patient with the myocardial infarction with STEMI. These two are important one-liners, guys, which has been used for diagnosis of reinfarct. CKMB can be used, which can be, in which case flipped LDH will be seen, myocardial infarction. Okay. Now moving this, currently we are in the laboratory investigations, guys. How do we diagnose it? With ECG, with cardiac biomarkers, moving on to cardiac imaging. Usually cardiac imaging is not being used as a first-line investigation of choice because it is not usually the diagnostic one. We can go for echo, guys, echo in which we can see the abnormal wall motion which is happening because of that, like what to say, the muscle is not receiving enough amount of blood supply. This echo can be done when the ECG is not diagnostic. One important negative point about echo is with echo, we can't actually differentiate this abnormal wall motion is due to scar which has happened due to a previous MI or a fresh acute ischemia. The abnormal wall motion might be happening because of a scar or it might be due to acute ischemia. So echo can be diagnostic, but we can't actually, it's difficult to delineate between whether it is due to an older scar or a newer ischemia. We have Doppler echo. Doppler echo is the one which will detect the presence of mitral regurgitation, guys, which is the most common valve-related valvular complication. The most common valvular complication of myocardial infarction STEMI is mitral regurgitation. We can go for cardiac MRI, which is the most common cause of death. An important complication of myocardial infarction is ventricular fibrillation. VFib is the most common arrhythmia associated with post myocardial infarction. This VFib can be prevented by administering lignocaine. We'll discuss that later, guys. Okay, but till now we have discussed about what are the basic concepts of how a myocardial infarction is getting developed. Dr. Tejaswi sir was explaining about what exactly is the anatomy, which artery will be mostly involved, which artery supplies which muscle in the heart. And we started with how that blockade actually happens, how that blockade develops, and what are the clinical presentation, physical findings, what are the lab investigations, how the ECG looks like, echo looks like, cardiac biomarkers, all these things we have done. Now let's start with the treatment process. Initial intervention, of course, we need to go with airway breathing circulation or CAB or anything if you want to explain, no problem. Oxygen has to be given. We have to maintain the saturation more than or equal to 94%. Patient might progress on to dyspnea because if the patient is suffering from pulmonary edema, the patient might progress on to dyspnea. IV access have to be found out because it's an emergency. We have to save the patient. And we can go for HIST. I don't know if you know about HIST. HIST is nothing but high intensity statin therapy. HIST is explained as high intensity statin therapy. which is atorvastatin, is administered at a dose of around 40 to 80 milligrams. 40 to 80 milligrams is the dose of which we call as HIST, high intensity statin therapy. It has been recommended usually for very high LDL levels, because the ability to decrease the LDLs will be more as the dose of statins tend to increase. Even though in clinical practice, HIST is not highly recommended, because patient might progress on to rhabdomyolysis or myalgia. But in case of life saving, if you want to save the patient, we have to opt for that HIST therapy or high intensity statin therapy. Aspirin can be given. Now comes the next famous question. Aspirin, see, please note it down. The usual aspirin which we get it in the market. Okay, the usual aspirin which we get it in the market is enteric coated. I'll repeat that. The usual aspirin which you get it in the market is enteric coated. So when the patient is suffering from myocardial infarction, of course, there will be an emergency drug which is there, not this drug, no, some drug will be there. You'll be having that emergency drug, and if it is enteric coated, even if the patient swallows up, it will take a lot of time for that drug to start producing its responses. So we have to administer a non-enteric coated aspirin. Non-enteric coated aspirin. So what's the dose which we give? Based on the recent guidelines, guys, 162 to 325 milligrams. 162 to 325 milligrams. Because if it is enteric coated, it has to be chewed and swallowed. Even if it is not, it is always advisable to be chewing the tablet and swallowing that to see some rapid response in the patient. No, sir, the patient is not conscious. The patient is just lying down like this. How can I make sure the drug is reaching inside the body? If we cannot administer that drug via oral route, we can administer it as rectal suppository. Right? We can administer it as rectal suppository. Okay, so these are the different ways in which aspirin can be given for the patient. So please note down that in case of emergencies, we have to start the patient with high intensity statin therapy. We have to start with aspirin. In the next one, even after administering it, if the patient is presenting with persistent chest pain, or if the patient blood pressure is getting raised up, or there is hypoxia due to pulmonary edema, then we can opt for sublingual nitroglycerin. Sublingual nitroglycerin can be administered as a tablet. Usually we used to keep it under the tongue, guys. Sorbitrate, a famous brand, is there. And 0.4 milligram is the dose which we give. Every 5 minutes, we have to repeat that drug dose up to 3 doses. Every 5 minutes, we have to repeat the drug dose up to 3 doses. Or we can opt for a translingual spray. We have a spray of NTG nitroglycerin. Again, the same dose, 0.4 milligrams every 5 minutes for up to the maximum of 3 doses we can administer. Now, for which case, now I have told you in which case I have to give it if the patient is breathless, or even after administering that, or if the patient is hypertensive, non-hypertensive, or if the patient chest pain is still been there, we have to administer this sublingual sorbitrate in those cases. Now, what if this patient BP is very much low? Systolic BP is less than 90 millimeter of mercury, or we can simply call them as a hypotensive, because nitrates are powerful vasodilators. It will suddenly decrease the blood pressure. What if already the patient's blood pressure is very much low? That is, if it is inferior wall, the patient's BP will be very much low. In those cases, this drug should not be administered. Or if it is a right-sided myocardial infarction, if it is a right-sided MI, again, this will further decrease the cardiac output, guys. So right-sided MI, nitrates should not be administered. And if the patient has already taken a phosphodiesterase 5 inhibitor like sildenafil for some medical uses, might be, I don't know for what they're going to be using it. Okay, so if a patient is under phosphodiesterase 5 inhibitor therapy, then these nitrates should not be administered. Please note down these sequences in which nitrates are contraindicated, okay? Because immediately in all the cases, most of the patients are taking up sorbitrate or NTG sublingually. So we have to know in which cases we should not administer this nitrates. That is an important question for the exams too. Okay, moving on to the next one, how to handle pain for the patient, guys. Morphine, yep, most of you would have known it. Out of this, the most important opioid is morphine. 2 to 4 milligrams can be administered as IV route. The dose is very much important. 2 to 4 milligrams given as IV route, followed by 2 to 8 milligrams every 5 to 15 minutes. We can administer morphine, guys, up to a maximum of 10 milligrams. Up to a maximum of 10 milligrams we can administer, not more than that. Usually we don't need to administer it. Okay, so what exactly does it do, guys? When you administer morphine, morphine is an opioid. It is a powerful, potent analgesic agent. Morphine has also got other capacities of decreasing the heart rate, decreasing the cardiac output. Whenever the heart rate is getting decreased, when the cardiac output is getting decreased, the cardiac muscles demand for more amount of blood will be decreased. When we decrease the demand, that progression to myocardial infarction, progression towards severity is also going to be stopped up in between. Well, that's also one important use of giving morphine. But please note down that morphine might also inhibit the sympathetic autonomic nervous system stimulation. So what's the function of sympathetic autonomic nervous system? Vasoconstriction, right? So when the sympathetic system is getting blocked, there will be vasodilatation in the periphery, causing a venous pooling. The venous blood is going to be pulled up in the periphery. Whenever there is venous pooling in the periphery, what do you expect? The venous return to the heart, that is also going to be decreased. So because of the decreased venous return, there will be decreased cardiac output and decreased blood pressure. Three important features of morphine, guys. And the second important feature is it also has got a vagotonic effect. Vagotonic effect, which means it will increase or stimulate parasympathetic autonomic nervous system responses. Because of that stimulation, as we have explained previously, there will be a decrease in the heart rate, and some patients might progress on to heart block too. Okay, so these bracketed ones are important features associated with the morphine, guys. Now, what if a patient lands up in this? What if a patient lands up in decreased cardiac output or decreased blood pressure? Simply just opt for a limb elevation. After administering morphine, please make sure the limb is getting elevated to prevent the decrease in blood pressure, or simply we can start the fluid, we can start the patient on IV fluid of normal saline. That will also prevent the increase the cardiac output by increasing the blood volume. But we have to make sure that the fluid is going up very much slow, because we don't want to load the blood with fluids which might progress onto pulmonary edema too. What about heart rate is getting decreased or heart block gets developed because of morphine? We can administer atropine, guys, because we know atropine is the drug of choice for bradycardia and heart block. We administer 0.5 milligram via IV route. That with this dose, we can reverse the heart block or bradycardia which might be developed due to morphine. These are the basic initial interventions, guys. That's a small recap of it. Airway breathing, circulation, saturation has to be maintained, IV access, HIST, which is high intensity statin therapy, aspirin, the drug dose which we give, sublingual nitroglycerin. Please make sure that the blood pressure is normal and the right-sided MI is not there for the patient. And morphine can be administered for the pain management. Now, based on the, as we have told, based on 2025 AHA recommendations and also recommendations based on the newer edition, we're going to be discussing what's the treatment process for, actual treatment process for myocardial infarction. First of all, we have to plan for a reperfusion strategy. Okay, reperfusion strategy is nothing but how we are going to be doing that surgery. The treatment of choice is always going to be percutaneous intervention, guys. Here we opt for a primary percutaneous intervention. Primary percutaneous intervention means we admit the patient. Even if the patient is, we can opt for an angioplasty or we can opt for a stent, any surgery which has been done without thinking of fibrinolytics. That is what explained as primary percutaneous intervention. Percutaneous intervention is nothing but, as we know, CABG, coronary artery bypass graft, or stent placement, or removal of the clot. Anything if you want to use, that's what called as primary percutaneous intervention. That will be the treatment of choice. It has to be done within a span of maximum of 120 minutes. That's the time which has been given. Less than 120 minutes from the onset of the MI, we have to opt for it. But what if the percutaneous intervention is unavailable within 120 minutes of first medical contact? from the first medical contact 120 minutes if it is unavailable, or if the symptoms is less than 12 hours, symptoms is there but it's not been long enough, or if there is no contraindications. In all of these cases we can opt for a fibrinolytic agents. What are these fibrinolytic agents? See, these are the drugs which tend to break down the clot, guys. If clot is being formed, usually what we can do, we can put a catheter there, we can remove that clot, and we can keep a stent over there, which is, we used to call them as drug-eluted stents. Usually we administer sirolimus, everolimus, lots of drugs are there. Okay, we can keep a stent over there, which will prevent that vasoconstriction from happening or vasospasm from happening. Instead, we can opt for a fibrinolytic agent. When you administer it, this drug will go over there, it will break down the clot, to dissolve the clot. That's what called as fibrinolytic agents. We have two important drugs which is currently being used. One is reteplase and tenecteplase. Reteplase, always please remember it as repeatplase. Please change the drug name of reteplase to repeatplase, because we have to administer 2 drug doses. We have to repeat the drug dose. Double bolus is the usual regimen which we give for reteplase, guys. The first bolus is administered 10 million units over 2 to 3 minutes. After like 30 minutes, we have to administer the second bolus of 10 million units for a period of 2 to 3 minutes. Well, that thing is not needed for a tenecteplase, a very, very important drug, a lifesaver drug actually. Tenecteplase is given as a single bolus injection, 0.5 an usual like dose which we use, 0.5 or 0.53 milligram per kilogram. It is given as per kilogram doses, not a fixed dose. 0.53 milligram per kilogram IV bolus. It must be administered slowly over 10 seconds. So this is how we can treat, we can kill off the clot, which is then we can dissolve the clot. Now comes the most important question. In which case we should not give this fibrinolytics? Very, very important question, guys. Why? Because not all the patients are suitable enough to give fibrinolytics. We have to opt for percutaneous intervention. Because with very much minimal availability of cardiologists in rural areas, most of the like hospitals are opting for fibrinolytics. We have to know in which case I should not give the fibrinolytics. Let's look into the absolute contraindications. There are multiple relative contraindications too, but here we'll be sticking on to absolute contraindications for the use of fibrinolytic agents. With a simple mnemonic, we can explain it. Samsung tab is the mnemonic. Samsung tab is the mnemonic. Remember the contraindications for fibrinolytics. Yes is for history of stroke. Yes is for history of stroke. Structural changes, which means if there is any previous cardiovascular lesion already for the patient. Stroke within a time of 3 months, within a period of 3 months, if there was or there is development of stroke in the patient. T here stands for trauma, history of trauma, and history of tumor. Any trauma which is happening over the face or over the head within a span of 3 months. Again, if the patient is suffering from a neoplasm, like cranial neoplasm, intra-brain tumors, brain abscess, any tumors if the patient is developing. A stands for aortic dissection. Patient is already been suffering from aortic dissection. B stands for any spots of bleeding if the patient is developing. This bleeding means all types of bleeding except for menses. Menstrual bleeding is not a contraindication for administering fibrinolytics. So please note down, these are the different contraindications for the use of fibrinolytics: stroke, structural lesions, trauma, tumor, aortic dissection, and bleeding. These are the absolute contraindications, guys. Multiple number of times we have seen this question in many different exams. This is very much important. More than exams, it's important in practice too. Moving on to the next one, we discussed about what is that percutaneous intervention. We discussed about the fibrinolytic therapy. Which drug do we give usually currently in our practice? Because tenecteplase, the drug which has been added up in the essential drug list, which has been released like 2 years back. They have added tenetiplase in it. So tenetiplase is available in most of the like referral hospitals. If in case, please note on the dose 0.53 milligram per kilogram is administered as IV bolus over a period of 10 seconds. In which case we should not give tenetiplase. Samsung tab was the mnemonic. What about the antiplatelet therapy? If the patient is being treated, with percutaneous intervention, or if the patient is treated with fibrinolytics. Percutaneous intervention, we can opt for ticagrelor, guys. Ticagrelor, all of these drugs are P2Y12 receptor blockers. These are named as P2Y12 receptor blockers, antiplatelet drugs. Has to be used because, as I've told, no, when that fibrous cap is getting opened, there will be a mural thrombus. That thrombus is primarily found because of the movement of platelets over there. So we have to administer an antiplatelet drug to prevent the further accumulation from happening, to prevent the mural thrombus from progressing on and blocking. The complete blockade should not be happening. So we have to administer an antiplatelet drug. Ticagrelor can be administered around 180 milligrams. Everything is administered as loading dose, guys. 180 milligram administered as a loading dose. Loading dose means a single dose, no? Like once dose we can administer. Or we can opt for prasugrel 60 milligrams, again given as a loading dose. One dose is given via oral route. We used to administer it as ticagrelor once oral or prasugrel once oral. Okay, once we have to one dose, we have to administer it via oral route. And this prasugrel has got lots of contraindications, guys. Prasugrel is contraindicated in patients with prior history of stroke. If the patient has got previous history of stroke or TIA, or if the patient is elderly, more than or equal to 75 years of age, in those cases, prasugrel is contraindicated. Ticagrelor is always a safer alternative. It has got a very minimal like contraindications. The only difference between ticagrelor and prasugrel is an irreversible P2Y12 inhibitor, whereas ticagrelor is a reversible P2Y12 inhibitor. So the incidence of bleeding and also that severity of bleeding is very much lesser with the ticagrelor, and we can easily reverse it back to. What if a patient lands up in overdose of ticagrelor? We have a specific antidote to, and that is bentrasimab. Ticagrelor, we have a specific antidote named as bentrasimab. Because of these advantages, ticagrelor is being preferred to be given as the antiplatelet therapy, given as once per oral 180 milligrams of drug dose, loading dose. So do we need to remember the drug doses? Yes, doctors, especially for emergency cases like myocardial infarction. All of these cases which we are discussing in our A to Z sessions, all of these sessions, the drug doses are extremely important. Okay. For those students who are watching it just now, we have we have discussed about many topics under this A to Z concepts. All of these videos has been uploaded in the DocTutorials MBBS curriculum. DocTutorials UG curriculum, under that, if you download DocTutorials UG curriculum, open that. We have a separate tab for it. This video is free for all. Anyone can actually watch it. Please go take further use of it. Okay, patients treated with fibrinolytic agents. Again, here we have to come up with the age value. If the patient is more than or equal to 75 years of age, or if the patient is less than 75 years of age. More than or equal to or less than, the drug is going to be same. Clopidogrel will be the drug, but the dose is going to be different. If he is more than or equal to 75 years, 75 milligram has to be given as loading dose, once oral. As more than as much elderly as possible, 75 milligram will be the stoppage value. Less than 75, we can administer 300 milligrams loading dose, once oral. Okay, sir, but we have not given. The patient has been diagnosed with MI, and we have shifted the patient for percutaneous intervention during surgery, and we come to know that we have not administered the antiplatelet therapy. Can we administer the antiplatelet therapy now? We have designed a drug which is again one more like reversible P2Y12 inhibitor, which is cangrelor. Cangrelor and ticagrelor, both of these drugs are reversible P2Y12 inhibitors, whereas clopidogrel and prasugrel, these drugs are irreversible P2Y12 inhibitors. So the presence of bleeding will be high for prasugrel and clopidogrel as compared to ticagrelor and cangrelor. Cangrelor can be given via IV route during the surgery also. That can be, we have the second basic options for it. A loading dose is administered and the maintenance dose, series of maintenance doses has to be given for that. These are the antiplatelet therapy for the patient. We have discussed about three major concepts. The first one is the reperfusion strategies. What is the primary percutaneous intervention? We discussed about fibrinolytic agents, which drug and what's the dose. Antiplatelet therapy, which drug and what's the dose based on the age of the patient. The last concept to be explained is your anticoagulant agents. So all of these drugs has to be given for the treatment of myocardial infarction. Within anticoagulants, the same sequence, guys. Patients treated with percutaneous intervention, patients treated with fibrinolytic agents. Percutaneous intervention, usually we treat the patient with unfractionated heparin. Okay. The usual dose which we administer is around 70 to 100 units per kilogram via IV bolus. That's the usual dose of anticoagulants. UFH stands for unfractionated heparin. Unfractionated heparin. So patient treated with the PCI, we administer 70 to 100 units per kilogram of UFH administered as IV bolus. What about fibrinolytic agents? Already there is thrombolysis which has been happening. So in those cases, we have two major options. Whether after administering fibrinolytics, you are progressing on to percutaneous intervention or not. If you are progressing on to percutaneous intervention, then again, we have to treat the patient by administering unfractionated heparin. Again, here the drug dose is going to be not that much as we have seen in that. Here we have administered a fibrinolytic agents, more prone to chance to land up in bleeding. That's why little bit lesser dose we administered comparatively. 60 units per kilogram is administered as IV bolus, followed by 12 units per kilogram per hour given as IV infusion. This dose is very much important, guys. We have seen questions asked about what's the dose of UFH which we give for myocardial infarction. Usually that's 60 units per kilogram administered as IV bolus, followed by 12 units per kilogram per hour infusion. It has to be continued for the patient. Okay, no sir, PCI is highly unlikely. We don't usually progress on to PCI. Then we have to treat the patient with low molecular weight heparin, which is enoxaparin. Enoxaparin is called as low molecular weight heparin. Again, here we have two different age bars. Okay, if you plan to administer low molecular weight heparin, age bar is also an important factor. What if the patient is less than 75 years of age or more than or equal to 75 years of age? Again, the 75 is a magical number over here. If he is less than 75, his body is capable. That's how we understand it. Less than 75 means not exactly like, oh my, from next month you are turning on 75. Good, you are there, and less than 75 you will start with this regimen. Not based on that. It's primarily based on the individual body and the individual situations where we have to take the decision to. We can administer 30 milligrams of intravenous enoxaparin. Very important, please note it down. 30 milligram intravenous is administered as loading dose, followed by 1 milligram per kilogram given via subcutaneous route every 12 hours. Okay, again, this sequence is important, guys. This dose and the sequence of dose, the drug which we administer. Please note down here we have enoxaparin given via IV route, followed by a subcutaneous route of 1 milligram per kilograms. What about he is more than or equal to 75 or elderly age individuals? That patients might land up in bleeding. So in those cases, we just skip the loading dose, right? That loading dose IV has to be skipped. We have to administer a little bit lesser drug dose as a subcutaneous route, which is 0.75 milligram per kilogram. There what we administered, 1 milligram we administered. Here we're going to be administering 0.75 milligram per kilogram subcutaneous route, again every 12 hours. Is that clear? Okay, sir, what if the patient is suffering from renal failure too? Again, one more question. If the patient is suffering from renal failure, we cannot administer the usual doses of low molecular weight heparin. In those conditions, we have to, how do we remember it? Simple one. Here 1 milligram per kilogram is administered, no? 1 milligram per kilogram subcutaneous every 12 hours. Here we have to administer it every 24 hours. As simple as that. Okay, the same thing over here, 0.75. I use that different color. 0.75 milligram per kilogram given every 12 hours. Renal failure every 24 hours, right? So that because the excretion is going to get hindered and the patient might land up in bleeding also. To prevent that, we used to do this. This is the whole treatment process, guys. Again, a small recap of what we have discussed about the treatment process alone. We'll keep it as simple as that. I hope we explained about the reperfusion strategy, primary percutaneous intervention. We explained about fibrinolytics. We told about tenecteplase and retiplase. We explained about the contraindications for fibrinolytics. Samsung tab was the mnemonic there. Antiplatelet therapy, what are the drugs? We have ticagrelor, prasugrel, clopidogrel, cangrelor, 4 drugs we have explained. Anticoagulants, unfractionated heparin or enoxaparin. What's the drug dose of EFH? 60 units per kilogram IV bolus followed by 12 units per kilogram per hour IV infusion. Enoxaparin, less than 75. This is the drug dose. More than or equal to 75, that's the drug dose. Again, drug dose is very important, especially for acute MI, status epilepticus, status asthmaticus. In all of these cases, the drug dose is important, guys. That's why we are discussing that in detail. Okay, with this, we have finished about this discussion, guys. Let's have, let's face few questions here. I hope you can answer those questions here. A 45-year-old who presented with sudden onset severe chest pain, most of you can easily guess because that's the topic, was detected to have bradycardia and hypotension on evaluation. What's the most probable diagnosis? So here the heart rate is getting decreased. Is that right? Yep. Here the heart rate is decreased. Thank you, everyone. Thank you. I hope. Sorry, I'm just looking into the messages right now. Hello, Tinu. Hello, Kishore. Hello, everyone. Thank you so much. Okay. If you want, you can just put up the answers over here. Yes, good, Dr. Kishore, you're right. The answer is inferior wall MI is the answer for the question because as we have explained, bradycardia hypotension is for inferior wall, whereas anterior is going to be the opposite one, hypertension and tachycardia. Okay, moving on to the next question. Most common valvular abnormality seen in a patient with acute MI. Most common valvular abnormality. We have discussed that in one point in our session. I hope you can answer that, my dears. Yep, I hope you can answer the question. Second question, anyone who can put it up? No idea? Okay, so we'll put up the answers over here. The answer for the question is mitral regurgitation. MR is the answer for the question, guys. Because we have discussed that already, the most common valvular abnormality seen with that is mitral regurgitation because of the papillary muscles is going to get hindered. That's why patient will progress on to MR, mitral regurgitation. Yes, good, Dr. Kishore. We'll move on to the next one. A 48-year-old man with chest pain of 1 hour duration is diagnosed as having acute MI. Which of the following features, if present, would most contraindicate therapy with fibrinolytics? This question is clear. Question is about what are the contraindications of fibrinolytics? Remember that mnemonic, guys. Samsung tab was the mnemonic. S is for what? A small recap. Structural and one more yes was there. Anyone who can answer that question in that chat box, guys? Yes, one structural, one more point. Anyone? Yes, we'll have a small recap here. Where's it? Yep. So here, as we can see, Samsung tab was the mnemonic. Stroke, structural, T is for trauma and tumor, A is for aortic dissection, B is for bleeding. Please note down, this is a very important question as per the contraindications of fibrinolytics is concerned. So based on this, the answer for the question is going to be, as most of you have guessed, good daughters, the answer is stroke. Option B, history of likely ischemic stroke within past few months. Well, that is the answer for the question. BP 160, 110 was previously an absolute, but now it is a relative contraindication. ST segment elevation ECG is actually not a contraindication. It's an indication for fibrinolytics. Previous aspirin therapy, it is not a contraindication. We can administer it. But if the patient has landed up in bleeding, then that is a contraindication. Okay, guys, so with this, we have finished about myocardial infarction and especially STEMI. I thank Dr. Tejaswi sir for being with us in the start to explain about how normally the blood supply works. And with that base which he has created, I have just built up a little bit more. And we explained about the pathophysiological concepts. We explained about why not all the patients progress on to MI, why some patients progress on to MI. We have answered that question. How the patient will present with what type of pain we have present. We have explained it, deep visceral pain on the central part of the chest. Sometimes it might radiate, might be associated with sweating and anxiety. There might be painless STEMI too. And some patients will be how to physical findings. Yep, substernal chest pain for more than 30 minutes with increased sweating, diaphoresis, strongly suggestive of it. Inferior wall hypotension and bradycardia, anterior hypertension and tachycardia. Then explained about the clinical symptoms. ECG, we explained about the criteria of how to diagnose the patient with STEMI based on V2, V3 and all the other leads, which millimeter of say increase in the ST segment elevation. We discussed an image of how the elevation actually looks like. Then we came up with the what are the different leads and which how to diagnose that. We explained about we explained about the cardiac biomarkers. Yep, here is where the cardiac biomarkers and which is the most earliest one, myoglobin. The late one is going to be LDH. We explained about flipped LDH and the diagnosis of reinfarct. Then we came up cardiac imaging, guys. We explained about echo, Doppler echo, cardiac MRI, and the cause of death in terms of patient with MI. Initial intervention, HIST, we have aspirin, oxygen, we have to maintain the levels. We can administer nitroglycerin, sublingual or translingual spray can also be given. All this thing has to be given under the tongue. And what are the contraindications for nitrates? We came up with morphine, how to treat the pain associated with myocardial infarction. And we came up with acute management of MI, reperfusion strategy, primary PCI. Then if PCI is unavailable, fibrinolytics, how to choose the fibrinolytics. What are the contraindications of fibrinolytics? In practice, we used to call it as thrombolysis. Both are one and the same, guys, don't worry. Antiplatelets, then we came up with the 4 important drugs to be explained. Anticoagulants, which patient to give UFH, which patients we prefer to give enoxaparin. And we discussed 3 important MCQs related to acute coronary syndrome. Thank you so much, guys, and we'll discuss one more topic as early as possible with inviting one more beautiful faculty to make sure that you understand it from the core. Thank you and good night.